Thank you all for coming, especially on Monday at 8 a.m. I even had a hard time to wake up, but I'm here, so kudos to you for being able, and thanks for the AAO committee for giving me this opportunity to give this topic, and my topic is effect of different expansion methods at different ages on the airway and posture. This is basically going to be a summary of years of work that we've been doing at University of Alberta, and I compiled and going to show you these right away. In the meantime, I'm a professor at the university. I'm also the director of, basically I'm the one in charge of organizing clinical trials at the university in dentistry, not only ortho, can be endo, perio. I'm the director of the undergrad orthodontics, and I'm also an Oilers fan. I'm a proud dad of a 7-year-old, and luckily she's also in the Oilers. Oilers are in the playoffs. Hockey is basically life over there. I'm from South America, which is soccer, but we don't get soccer, so let's go Oilers. I declare I don't have any conflict, no interest. Everything I own is my wife's, my money, everything. So this is some photos of the university itself. We live in a small city, 1 million people there, and it's cozy, it's nice to raise a family. Whenever you want, you can come by. And if you don't like the heat, we had our last snowfall just last week, right? But it disappeared, so don't worry about it. So now going into the topic itself, what is maxillary constriction? So the characteristics we usually know, and if you've seen other lectures here, this would be just a reminder. It's a patient that presents a narrow palatal vault, a narrow intermolar width, wide buccal corridors. It can have a posterior crossbite, either unilateral or bilateral, and mandibular interferences or functional shift. And the etiology of these can be skeletal or dental. So basically, for expansion, there's different philosophies and appliances. With the philosophies, it can be either slow, semi-rapid, which would equal 1 turn per day, rapid, which would be 2 turns per day, or surgically assisted expansion. And with appliances, nowadays we have the tooth-anchored expanders, the traditional Hyrax. The bone-anchored expanders, we have the Moon expander, Dresden expander. We have several out there in the market. We can even do it with braces and wires. One of the one that we use or we know more is Damon. And recently the clear liners, which have been on scrutiny because every other appliance before the clear liners are mediable as they present. So here in the university we do a lot of clinical trials, and all these involving maxillary expansion. So we do it in different ages, in different ethnicities, in different types of patients. And with this, we do collect a lot of records. We have a database, and from there we start collecting or answering questions that arise during the times in terms of, do we really change the airway? Do we really benefit the patient in their lifestyle? Do we really do skeletal dental changes, and so on, with all the different appliances? So I like this slide especially because this shows that in the clinic, we have days where we just do screenings of patients. And when the screening comes, the patient, we identify, are they suitable for a research? So once we identify, oh, this is suitable for research, we just grab the information package and consent form and give it to the patient. So that makes a good system where we can really fast track or get recruitment for our clinical trials on the go. Also, a little reminder about obstructive sleep apnea. It's a chondritic condition that can affect both children and adults. Some of the symptoms presented is several episodes that can be complete or partial collapse of the upper airway during sleep. And if this is severe, it can shift towards mouth breathing. There's a reduction of the airway flow, and patients are usually awakened because of that. There are many studies that have shown the effect of RME on upper airway, but there's limited studies that we saw a growth of them during these years, but there's still limited study on the relationship with adults. So this graph shows the difference between sleep apnea between children and adults. So the age, different. Gender, there's no difference in children. In adults, it's mostly in males compared to females. Obesity in children is less. In adults, the majority have obesity. Tonsil adenoid hypertrophy in children is more frequent than adults. Daytime hypersomnia is more frequent in children, less frequent in adults. Daytime attitude, you have a poor school performance, hyperactivity in children, while in adults is severe drowsiness, decline of superior function. So what does the research tell us concerning expansion? that they can increase the nasal permeability, the nasal width, it can increase the nasal cross-section area and volume. Thus, what is the premise? They enlarge the palatal space, reduce the airway resistance that causes a less negative pressure during ventilation and is beneficial in patients with obstructive sleep apnea. So what can we say from this? When we enlarge the palatal space, we're creating more space for the tongue. So the tongue improves its posture, and that facilitates an increase of airway space, thus reducing the chance of sleep apnea. So let's go what our studies have been saying. What is the question? What is the effect of maxillary expansion in airway and posture at different age groups? So the first one will go from age group 5 to 8 years old. So we were lucky that there's a general dentist in Alberta that expands kids very early. I myself, I wouldn't start until 7 years old, but this dentist does it from 4, 5, 6 years old. And he really is interested in the effects he's having, so he shared the records with us. So we explored the impact of maxillary expansion in the Apnea-Hypopnea Index, AHI, in young children diagnosed with maxillary transverse deficiency and OSA. The primary focus was addressing the maxillary constriction while also assessing the intervention's impact in managed OSA. These kids have been diagnosed to have OSA. This focus on very young children that is not extensively studied, there's almost no research out there for this group, provides a unique perspective in early expansion effects. So what do we do on these patients? Basically, these patients needed expansion because of skeletal deficiency, not just because they had airway problems. They presented a skeletal problem. They had the RME was placed on all the children, and also all the children had a take-home test to analyze their AHI, right? And in this case, we use the sleep ring, which has been validated for children and adults. So patients that presented an AHI greater than 1 were also referred to the pediatric pulmonology sleep medicine for the in-person assessment to continue their treatment. So overall, we had 19 patients. You can be distribution almost equal between males and females. Primary dentition, there were 6, and in mixed dentition, there were 13. So what we found was in AHI, before and after expansion, almost no change, right? There was very minor reduction if you really see the numbers, but I don't consider that a difference. The mean AHI before and after broken into genders, you can see that the male patients even had more episodes, while the females did have a reduction in episodes. The magnitude of change, we saw that there was a reduction in kids that had all primary dentition, while in mixed dentition it pretty much stayed the same. And when we related it to the amount of expansion, these kids had almost 8 millimeters of expansion in molar to molar, and there was almost no correlation, and it kept the same. So what I can say is that although there's literature that supports that maxillary expansion can be used to intervene pediatric OSA, I would say to take that in caution, because this shows that we have to develop a personalized approach that accounts for patient-specific characteristics and treatment responses is essential for optimizing therapeutic outcomes in pediatric OSA management. Why am I saying that? Because from all the patients, we did see that some of the patients did benefit, others didn't, others got worse. So that's why we can't just go ahead and expand everybody just to fix the airway. This is a multidisciplinary problem which should be addressed by different groups. Now, concerning the posture, I understand that's the topic here, but unfortunately with these kids, we weren't going to be taking x-rays. Like the dentist didn't take cephs every time on these kids, so posture was not analyzed. The lateral cephs were not taken, and we checked the literature, and there were no literature with patients younger than 8 years old that showed posture analysis. So now we can go to the next group, which was the 8 to 17 years old. So in this, we worked with a group from Peru and people from Canada where we did this systematic review. And the systematic review was basically to see the effect of RME on the cervical posture, head and cervical posture. So after doing a scrutinized review of all the literature available, we found that there were 6 articles to be shown, and the summary of the articles are presented here. And if you see these articles, you can see that they're no younger than 8 years old, and not older than 18. And lots of these, the most they follow the patients were 12 months, not more. Right. So what they found in summary was that there was a craniocervical angulation decrease, there was a head elevation flexion decrease, a cervical lordosis increase, and inclination of the cervical spine increase. So that's basically the summary of all these. But to conclude, we can see that RME does benefit children during the growth period by improving the head and cervical posture. But we have to be, again, cautious. There's the low level of evidence on this because there is a decrease in craniocervical angulation, but also see the numbers. The numbers are really not that high of a difference. There is low level of evidence in the decrease of head elevation. There's a low level evidence of the increase of the cervical lordosis or the inclination of the cervical spine. So some of the articles found there, here would be a summary of them. I could say that several studies see relation between expansion and posture, but lack studies on bone-anchored expanders and long-term results, which is approximately 12 months, like they analyzed no more than 12 months. Some example conclusions that they arose was RME is capable of increasing nasopharyngeal airway adequacy in girls, and this leads to a decrease in craniocervical angulation. The clinical importance of the results is yet to be justified. So they understand, although they found differences, it still needs to be analyzed, and we can just take it and consider that all the patients will have that effect. Another study presented, the results of the present study suggest that RME has a capacity of improving the fall risk. So basically it improves the posture. So after seeing this, one group that we work with in Peru, Desiree and Joanna, did a thesis on basically evaluating the craniocervical posture in rapid maxillary expansion treatments. So what they did, we have a sample where we had Hyrexis and bone-anchored expanders. This is mostly the Dresden style, which has the mini screw going between the 5s and 6s in the palate. It's not bicortical, it's only one cortical, but the expansion and everything in the protocol is the same. 1 turn per day for both appliances, and we go from there. Now, with the review, we found that there's several ways of analyzing the cervical posture, the craniocervical posture. And all these measures have been validated and used several times. So we just go and choose one for now, and we have another thesis choosing other measures to see if there's a difference. So, and overall, what we know, maxillary expansion causes skeletal change, causes dental change, causes airway change. The sum of all these, it is expected that it will reflect on the posture of the patients. So, our objective was evaluate the craniocervical posture in rapid maxillary expansion treatments using bone-anchored and tooth-anchored expanders. So they had CVCTs, pre-expansion, and at the end of the whole treatment, basically 24 months post-expansion. We had 3 groups, a tooth-anchored, a bone-anchored, and a control. You can see that they've been pretty similar distributed. And the angle measured was the SN and OPT angle, which is the ratio between the odontoid process and the anterior cranial base. What they found was the control pretty much showed an increase of the angle, meaning that the patients were tilting their head more upward, right? The tooth anchored, almost no change between those time points, but the bone anchored showed a decrease, right? But again, look at the numbers. What the sizes of the numbers? 2 degrees, 0.68 degrees, negative 1.6 degrees. So realistically, that can be measurement error, right? But I'm just showing this. When we compare between the tooth anchored and the control, we see that there was almost no difference, 1 degree between both. But when we compare the bone anchored with the control, there was more. There was almost 3.5 to 4 degrees of difference. So what were the conclusions? The craniocervical angle in the bone anchor group decreased, forward bending of the cervical spine, and the control and tooth control groups did not show a significant change. But again, we have to see the raw values, right? So I wouldn't just expand just to improve the posture of the patient if I just follow these results. So after that, let's see what's the effect of expansion in airway. I know you've seen several lectures, and I've been in those lectures that saying, oh yeah, the patient wanted to improve their airway, so I just expanded. But the reflect is the patient didn't have a crossbite, the patient didn't have skeletal transfer deficiency, so basically the purpose is expand because we would increase the airway. So we did this umbrella review, and this was in the group in the University of Alberta, where they analyzed all the systematic reviews out there. There's a lot of literature out there on this topic. So what was found? Basically, that at the nasal cavity level, 10 to 35% increase in volume after RME. At the nasopharynx level, there's up to 25 degrees increase in volume after RME. And in the oropharynx, it's still controversial. Some didn't find a result, others did. So there's no magic number there, right? And all the studies did this analysis with a Hyrax, so a tooth-anchored expander. So the conclusion was that there is shown that there's a significant amount of research published in RME changes and upper airway, but what is lacking is that, is this change reflecting in the lifestyle of the patient, or is it reflecting in the function of the patient? So it is not clear that the upper airway dimensional changes necessarily imply an improvement in actual breathing function. Right. So I do have to thank the team at the UFA. Like at the upper right photo, you have all the staff and radiologists there. They helped all these clinical trials making this possible. And we have photos of our residents over here. Some of them are present here. Thanks for coming. And you can see in the bottom photo, those are our first-year residents, and they're pretty happy because they're basically showing 2 fingers and not the alternative, which could be very bad. So what are the questions that then we analyzed with trial we're doing? Basically, there are differences in the oropharyngeal volume and menical cross-sectional area after expansion. Are there differences in volume and MCA between different treatment groups? And what's the difference between subjective breathing capacity? Now we want to see if the patient really are noticing that they are breathing better or not, or their lifestyle changed. So this is a retrospective randomized control trial with data ratio allocation of 1:1, 11 to 17 years old with unilateral and bilateral crossbites with two treatment groups, Hyrax or Damon appliances. And this was all done with CBCT analysis. So we have a high-risk group of 29 patients and a Damon group with 31 patients. So basically we had the CBCTs, these are characteristics, 0.3 voxel size, 16 by 13 centimeter field of view, and taken at 3 time points, at before treatment, 12 months, and at the end of all the treatment. So we have now long-term, at least 24 months, right? And the CBCT, we assessed it with 2 different softwares, the in vivo and Dolphin software. And basically the boundaries of the airway, these are listed here, and those boundaries have been validated and is pretty common in the literature out there. So this would be a perspective of some of the patients that we saw. This would be what we see when we do the airway segmentation. And what was found is that the Damon group didn't have any change in volume capacity or an MCA. Now, the Damon group, which is a tooth anchor, braces, and arch wire, are we really improving the airway or not? We don't know. And we need studies like this, especially with the new gadgets coming out from like removable expanders and so on. While with the high-rise volume, we did see a change. We saw it at 12 months, and we saw it at the end of treatment. So the high-rise group did show a change, an increase in the volume and an increase in the MCA. So now we'll see, does this reflect in the patient's capacity of breathing or what they feel if they breathe better or not? So we use the NOSE questionnaire, the nasal obstruction symptom evaluation, 5 questions. Each question you can rate at 0 to 4. Once we get the value, we multiply by 5, and that gives us a better number to do the analysis and characterize it between mild, moderate, severe, extreme. So what was found is that no significant changes were seen. They basically didn't feel that there was an improvement in breathing or worsening of breathing and so on. So although we expanded, we got an increase in airway, but it doesn't reflect in the function. Right? So I will give a couple of examples here. Although this is a mixed dentition, it's younger than the 11 group, but you can see here, we did this patient, we expanded, and you can see how especially the oropharynx has increased, right? There was a better tongue position after 12 months. Now we have another patient. Here, same way, we expanded, but I don't see a big difference between the oropharynx from before and after. So can I really say that airway is improving, like expansion is improving the airway? It's increasing, but sometimes not consistent on every single patient. So what can we see here? Basically, the high-res group did show an increase in dimensions. The Damon group didn't show an increase in dimensions. So what can we conclude here is, I'll be repeating myself, don't expand everybody just to fix airway. Okay, so if the patient comes, doesn't have skeletal or dental problems and transverse, but they want to improve their airway, basically it's a coin toss. And now we can go with a group that is 17 years and older. So we have the surgical group and we have the MARPI group, right? So these are, the MARPI would be like moon expander, as you can see here. So what we did is that we're going to do an analysis on a trial that we're comparing two bone-anchored expanders non-surgically applied with patients 17 and older. Treatment group A was the Dresden expander, which consists of also 2 mini screws, one on each side between the 5s and 6s, compared to the moon expander, right? The turning protocol was with the Dresden expander, 1 turn per day. With the moon expander, because it's a wrench, we had to turn twice a day to get the similar amount of expansion daily. So the inclusion criteria, 17 years and older, with present maxillary transverse deficiency, at least 5 millimeters, and unilateral or bilateral posterior crossbite. The exclusion criteria, syndromic patients, that if they had orthodontic treatment before, if they had large tori or a canted palatal plane, right? And you can see the distribution. This is still ongoing. We're still collecting. So Dresden had 5, Moon had 8, pretty much similar in ages, 21 to 24 years of age. So what are the questions? Are there differences in the upper airway using objective and subjective measures between appliances? The objective measures were basically the volume of the different areas of the airway. The subjective measures were obtained by the nasal obstruction symptom evaluation, right? And then the question 2 was there a difference within each expansion in terms of all those values? So what we did with these patients also is that we're analyzing the peak nasal inspiratory flow. So what that does is that we tell the patient to breathe through this tube, and we analyze the force and how much they can move that gadget inside the tube, and then we register in numbers. We do it when they do it through the mouth, and when they do it through both nostrils, and then we cover one nostril, they do it through the left nostril, and then we do the opposite on the right nostril. This method has been also validated to give us a perspective of what the patient is doing. So each patient has clinical charting, diagnostic exams, and CBCTs. We have the 2 set of records before and after expansion. Now, being these adults, I do take a CBCT once I confirm that there was expansion or not, because I need to verify if the suture was split, because if the suture wasn't split, then those patients would have to go to surgery. So that was the justification of that. We activate the appliances, and once expansion is achieved, the space forms between the 2 incisors, we take the 2nd set of records. We analyze the nasopharynx, oropharynx. We put Cs. This is the common dolphin way of measuring the airway, and the cross-sectional area. We also did a small measurement error in terms of volume of airway, because I can show you numbers and show, oh, look how much it expanded, how much it increased. But realistically, how much is that difference in tangible? How tangible is that difference? For example, we found that for the airway, for the nasopharynx, the measurement error was 4.5 drops of water. So we got that equivalence. While the oropharynx, it was 5 drops of water, right? So that gives us a little bit of perspective in terms of the changes. So when we did the analysis, what did we see? We didn't see a statistical significant difference between the volumes found after expansion compared to initial, and we didn't found a significant difference or change between the force of breathing with a patient when they breathe through the tube or not. When we did the nose questionnaire, there was no difference in the median nose questionnaire also. So the severity, but I have to make a note that these patients were considered mild before and after treatment, but they didn't feel an improvement in their breathing themselves. So what can we conclude? No significant difference were found between the 2 groups, so both expanders acted the same way. The Moon and Dresden expander showed to have no significant effects on upper airway dimensions and function. So what do you think I will say? Don't expand everybody just to fix the airway, right? And I'm having a lot of adults coming and asking to do that. And I don't know here, but where we are, we're having a lot of dental hygienists referring patients because they want us to expand them to improve the airway. So I don't know if that's common here, but we're having that. So I want to also give an example. Why do we have to expand everybody? If we expand everybody and they are not presenting the problems that we would fix for expansion, we can have this happen. So this is a case that was transferred to the clinic I supervise, where they didn't want to do extraction, they just wanted to expand the patient. And unfortunately, when we saw it, the case was transferred, we noticed, okay, let's extract because those incisors are already parallel to the palatal plane. So we have to just retrocline them. So we extracted, and then we took a CBCT because we were doing Propel. I just want to see the amount of bone and where to put them. And this is a case where you go, why did I have to take a CBCT? This is what we found. And when you see clinically and you put your fingers around there, I could even palpate the apexes. So that's also telling you in caution. Be careful to not just expanding everybody. There has to be a reason why, and airway alone is not a reason. So now we are not stopping there. There's new analysis coming out that we're doing. We've developed a computational fluid dynamics analysis. We're doing a pressure drop analysis on these patients to verify it's on the works. We are having promising results. Some are presenting that there is an improvement in that dynamics, but it's in the process, so I don't want to give false information right now. And concerning with posture, unfortunately, there are no studies with posture in adults, so that's a good topic to start. And I'm going to have the first-year residents coming in. Hopefully one will want to do that. But there are lots of studies concerning cervical posture improvement after class 2 treatment. And here are some of the studies. There's several out there, and treating TMD. And their conclusion was that although there's an improvement, there is still no evidence related with expansion. So we are still working. We are still expanding. I'm doing a lot of those. Every Wednesday is basically clinical trial day for us. And all the patients that come at different ages, they all have the same problem. We just put the expander in because they need the expansion and just collect the data from them. And with these trials, we're also trying to prove statements that arise every year in terms of new things that expansion does. So we go ahead and say, okay, let's try to prove it. And sometimes we can confirm, sometimes we say, nope, it doesn't happen. So again, I would like to thank the AAO for giving me this opportunity. I couldn't do this with my wife and kid, although my kid is making me wanting to sleep more. But that's the life of a 7-year-old. And I have to give a special thanks to Dr. Kapenakas, Dr. Habibnia, and Dr. Linyan because they have participated in lots of these projects. And there, I can leave it there. Thank you.